So the first category is programs. And think of this as the delegation of core agency functions related to running the Medicaid program to the university partner. We take over and manage those functions on behalf of the agency, in essence, as if we were an outsourced vendor. We don't think of ourselves as an outsourced vendor because we're a sister agency. As a public university, we are a public agency and public employees, just like the agency's employees are. But we function as if we were an outsourcer. Projects, which we also manage on behalf of the Medicaid agency, are defined in the way that a project management office would define projects. They're time limited. They have a beginning, a period of work, and a defined end. And we do run and manage quite a few projects on behalf of the Medicaid agency. And then finally, there are what we call embedded functions. University staff working side by side with agency staff as if they were all employees of the same organization, performing core functions and fully dedicated to a role within the agency. And generally, I'll finally add here, generally with dual reports. Their employment is within the university, and so they report up through the university, but their work is within the Medicaid agency, and so they ultimately report up to the Medicaid director on that side. So why would a partnership like this develop, and why would a Medicaid agency want to turn to its state medical school to do all this work? And there are a number of reasons. When you're talking about employing physicians, public agencies often have a difficult time recruiting and retaining the level of talent that they would like in a public agency setting. That's not impossible, and many physicians are employed within public agencies, but it's a more natural fit, and it's also an attraction to many top candidates to be able to hold a faculty appointment and either do a little bit of clinical work within the medical school or a little bit of teaching or a little bit of both. It has, in our experience, led to improved stability in the role, and we tend to keep people in that role for quite a long period of time, whereas in many agencies they turn over fairly often. There is strong alignment with the public university medical school mission, and this is a point that I'd like to emphasize for a moment. Some of the elements of mission that our university, our medical school, and many others hold include developing systems for measuring health outcomes and performing research on program effectiveness, providing oversight of clinical staff and the development of clinical policies or core areas of expertise, the ability to bring expert consultation on program design and evaluation. We like to say that we have the entire faculty of the medical school behind us. We certainly don't employ physicians in every possible area of specialization, but we have them available to us because they're our colleagues on the faculty. And then we have, as any university does, we have core expertise in applying for and managing grants and contracts on behalf of the Medicaid agency. So these are areas of expertise and alignment with the university mission, as well as the mission element of public service. There are also opportunities in working within the agency to do translational research within the public programs and to implement the results of research done at the university at scale within the agency. We have more flexibility than many public agencies do to change and evolve our staff to meet ever-evolving agency priorities. And we're generally able to bring a cost model that is more advantageous for the agency than turning to commercial firms for the same kind of work. So a little bit of background on the history of our Office of Clinical Affairs. It has been in existence for over 15 years. It started originally with the Medicaid agency, as I mentioned a moment ago, turning to the medical school to hire a medical director. Now, I want to add that this is not a unique situation. There are more than 15 Medicaid agencies nationally that work with a public university to employ their medical director. What is unique about our Office of Clinical Affairs is the extent to which it has been built out beyond just the employment of the medical director. Shortly after the medical director was hired 15 years ago, it was expanded to include the management and oversight of the pharmacy program, and I'm going to talk more about that in a few minutes. And then other functions were added over time: utilization management, quality measurement and improvement, data analytics, care management and case management, oversight of the Medicaid dental program, and expert consultation in behavioral health. So the first function that I'm going to describe briefly is medical leadership and medical management. This is performed by the Chief Medical Officer. Our current Chief Medical Officer, my successor, came to us from a managed care career and provided medical directorship to some of the leading health plans in the state. And as we sought to continue to evolve the Medicaid program into the future, we felt that expertise of having managed commercial health plan and commercial lives would be most valuable. We employ several associate medical directors who generally are physicians with expertise in one of the primary care areas: internal medicine, pediatrics, family medicine, and sometimes OBGYN. And then sometimes we have fractional associate medical directors in areas like surgery and psychiatry. Some of their work includes convening and coordination of the medical leadership of the managed care organizations through which the Medicaid program contracts, and provider relations within the providers, both of the Medicaid agency itself and the providers of the managed care organizations. The dental director does essentially the same with the dental community in the state, as well as managing the dental claims vendor and managing the network of providers. The medical directors provide clinical support to the agency in the appeals process. Almost any prior authorization or utilization management decision that goes adverse to the provider will be appealed through a formal appeals process, and all the clinical support around the appeals is provided by the associate medical directors. We also provide medical leadership in benefit expansions. So just as a couple of examples, recently Massachusetts changed its coverage to include coverage of applied behavioral analysis in autism, or ABA services in autism, and there was an extensive policy development process where the clinical leadership came from the medical directors in the Office of Clinical Affairs, and similarly, the Mass Health Agency recently went through a process to evaluate coverage for transgender services, and again, all of the clinical research and policy development came from the medical directors. And finally, collectively, they provide oversight to all clinical staff and clinical functions within the agency. A little bit more about our pharmacy program. The pharmacy program was shifted to the university, coincident with a full redesign of the Medicaid pharmacy program in this state. And the design that was developed by our still current leader and director of the pharmacy benefit made it a fairly unique program. This is a program that is class-leading in its performance, with both some of the lowest per capita costs of any Medicaid program in the country, while still allowing unusually open access to both branded and non-branded agents. It's something of a point of pride in our work. It has been developed so that there's a preferred drug list that gives no preference to any one branded agent over any other, and relies mostly on very high generic penetration. And we've been able to do that and continue it for many, many years. This particular function in the models that I described a moment ago is both embedded and a fully managed program, meaning that the university is responsible for the pharmacy program for the Medicaid agency in its entirety. We have a small number of embedded staff, about 8 or 9 staff within the Medicaid agency who are fully embedded and work day-to-day, side-by-side with the Medicaid staff. And then we have a team of more than 80 who are at the university's location who perform what I like to call the back office part of managing the pharmacy program. The embedded staff include the pharmacy program director and the clinical manager, a group of pharmacy claims analysts who analyze the claim data, folks doing the oversight of pharmacy claims processing, and the claims processing is done by a vendor. So we also manage a vendor contract, and the vendor receives and pays, adjudicates and pays all the claims. We oversee the preferred drug list or formulary, and conduct all the provider relations with, in this case, with dispensing pharmacists, all the dispensing pharmacists around the state who fill scripts for Medicaid patients. The program part of this, the non-embedded staff who are at the university location, among other things, do drug class reviews to aid in the selection of preferred drug list agents. They do pharmacoeconomic analysis, comparing all of the agents in a class, trying to figure out which are the most cost-effective. They do all of the prior authorization. Most of the utilization management is done through prior authorization of agents that are either not on the preferred drug list or are in a second tier. They do all of the drug utilization management and drug utilization review. And they also now administer on behalf of the Medicaid agency medication therapy management programs for particular classes of patients like congestive heart failure patients. Another group within the Office of Clinical Affairs does all of the Medicaid agency's utilization management. So this is performed through a mix of internally staffed functions, our staff, mostly nurses, and contracted vendor programs. So as examples, the acute hospital utilization management program is done by a vendor. The university develops and puts forth the procurement for that vendor. The vendor is selected and issued a 5-year contract. The Office of Clinical Affairs oversees and manages the vendor and then ultimately reprocures the services at the end. These have been highly effective programs. The acute hospital vendor, for instance, in the most recent period, has had a return on investment of about 11 to 1 to the cost of the program, just simply in finding medically unnecessary hospitalizations and denying payment for them. We also have another contract for non-acute provider reviews. So these include post-acute services, outpatient services, and non-physician providers. In-house, we do prior authorization for a variety of services, including surgical procedures, physician services, certain medical devices. These are performed by the associate medical directors, and then we have nursing staff who do prior authorization for non-acute hospitalizations and some other services. The prior authorization for other services, like long-term services and support, durable medical equipment, personal care attendants, and other services are performed as a program by another group of staff who sit at the university location. Within the Office of Clinical Affairs, we have also developed what we call the Mass Health Quality Office, which does all of the quality measurement and improvement on behalf of the Medicaid program. So they are both internally and externally facing. Their internally facing work really involves working with the agency staff and the agency programs to do their own performance reviews, their internal performance reviews of their program, to develop data and metrics to manage the quality of the service being provided to members. They also do externally facing work, and the externally facing involves working with managed care organization and provider communities selecting measure slates for both state plan amendments and waivered services as well as core services. They provide leadership to responses to CMS requirements for new measures and new measurement, and they identify areas in need of performance improvement by continuous monitoring of trending of Medicaid paid benefits. We have yet another group that does data analysis and business intelligence for the agency. They do all the utilization trend reporting. Through a variety of mechanisms that I won't go into detail on, they identify aberrant patterns of utilization and aberrant patterns of billing and support the Attorney General's Medicaid fraud unit in going after fraudulent billing. They perform ad hoc analyses for agency executives, develop comparative reports for program leaders and agency leadership, as well as a lot of the analytics support for the development of new initiatives. The last couple of minutes, I'm just going to talk a little bit about leadership of demonstration and pilot programs. This is one of the areas where a university partner can be particularly helpful to an agency. This is work that academic institutions and academic departments and faculty are really accustomed to doing, and they can provide both flexibility and surge capacity to agencies that often just simply don't have spare capacity to either go after or manage demonstration programs. We are well positioned to link demonstration programs closely to ongoing activities at the agency as a result of our embedded mode of operating. And we bring expertise in multimodal and mixed methods, both quantitative and qualitative, and survey evaluation in order to evaluate new pilots and demos. And finally, the university brings an obvious interest and ability to disseminate results of demonstrations by publishing them and speaking about them at national venues and conferences. So I'm going to give just a couple of examples of demonstration programs and the role that the medical school played in these. The first was the Patient-Centered Medical Home Initiative. This was a statewide 4-year-long demonstration. It was multi-payer in approach. It was a very high priority for the administration then in office in state government and the Secretary of Health and Human Services. And the university, the medical school, essentially ran this entire initiative from top to bottom. That included both the design of the program and the design of the novel payment methodology to be tested, all of the provider and payer engagement and education to bring them on board in order to be able to carry out a multi-payer initiative. We did all of the technical assistance to the primary care practices that engaged in this initiative, and this included both private practices and community health centers. We developed a data portal for them to report their quality measures. We provided the reporting back to the practices. And then in the end, a different and somewhat firewalled group did the program evaluation and has been disseminating the results, publishing and presenting at conferences. That, by the way, is a program that ran from about 2009 to 2014. And the second example is the CMS CHIPRA demonstration grant. This was a demonstration grant that was authorized by the CHIP Reauthorization Act of about 2010. It was a 5-year grant. 15 grants were issued to some to single states, and ours was a single state grant. Others were to multi-state consortia. In this instance, it was a very highly collaborative project. The Medicaid agency was the lead. The PI, me, was the university-employed chief medical officer of the Medicaid agency. The collaboration included the agency itself, the medical school, the Regional Health Quality Coalition, which is the acronym is up there. That's the Massachusetts Health Quality Partners, or MHQP. And the regional leader in pediatric care, Boston Children's Hospital. And this coalition worked on this initiative for 5 years. We formed the Sustainable Child Health Quality Coalition for the state, sustainable in the sense that it endures after the grant funding has ended. We tested and reported on a group of pediatric quality measures in a sample of pediatric practices. We supported the development of some new and innovative pediatric medical homes in 13 practices. And we developed a handful of new child health quality measures focusing on care coordination. So I think I'm getting the signal that my time has just about run out, and I'm going to stop here and hand it off to the next presenter, but I will be on the line to the end of the webinar for questions and answers. Thank you.
Great. Thank you very much, Dr. Polikoff. That was very helpful. Thanks for sharing the UMass perspective on adding value to the Medicaid partnership. Next, the Ohio Colleges of Medicine Government Resource Center will share examples of academic research which supports state policy, state agency healthcare policy. First, Dr. Jessica Crane, Director of Healthcare Integration, will present quality improvement projects. Then, Heather Reed, our Healthcare Access Program Director, will present the Healthcare Access Initiative. Please continue to ask questions in the chat box, and UMass and GRC will continue to answer them at the end of the presentation.
Okay, hello everyone, good afternoon. I'm Jessica Crane, and I would like to share with you some work we've been doing around quality improvement. The state often has need for, thank you very much, for some technical assistance to basically address areas that are high priority for safety and for cost. And as David described, when Medicaid when the Department of Medicaid partners with the universities on these initiatives, Medicaid is able to draw down the federal match from universities' kind of unrecovered facilities and administration, which allows us to substantially increase the budgets for these projects. And in addition, through the university partnership, the state can draw upon the expertise of the academic leaders in our colleges and universities to really lead these projects. So two projects that are actually sponsored by the Ohio Department of Medicaid in collaboration with the Ohio Department of Mental Health and Addiction Services are up on the screen for you here. One example is one of our larger projects called Ohio Minds Matter, which was basically a response to national and state concern about the rising rate of atypical antipsychotic medication use and polypharmacy among children with mental health conditions in the Medicaid program, particularly children in foster care, but certainly all children in the Medicaid program. The other project listed here is called the Maternal Opiate Medical Support Project, and it was established basically to try to promote best practices for opioid-dependent pregnant women to improve their health, their infant's health, and to reduce the cost of neonatal abstinence syndrome. A couple other examples I wanted to share with you. These two more recent projects funded by the Department of Health focus on maternal infant health. The Gestational Diabetes Project is identifying women at risk for or who have gestational diabetes and screening them early, and also trying to make sure mostly that they receive postpartum care and postpartum screening for diabetes. And then finally, the Smoke-Free Families Project is targeting smoking cessation efforts toward pregnant women and women of childbearing age in the Medicaid program, a third of whom use tobacco in the third trimester. So these are just a few examples of kind of some of the projects that we're leading right now, and I just want to tell you a little bit about the process we use for these projects. For all of these projects, we are basically using a modified version of the Institute for Healthcare Improvement's Breakthrough Series collaborative model for improvement. And that model focuses on really rapid cycle testing in the practice setting to identify interventions that work, the model relies on stakeholder collaboration and kind of data transparency and really kind of basically developing and rapidly testing interventions to help sites accelerate the implementation of best practices and establish kind of a culture of learning and innovation and collaboration to really get these things going and rolled out. So our role at the GRC is, first of all, to identify academic experts. We identify folks in the colleges of medicine around the state, and we contract with them. We have, for these projects, identified leaders in psychiatry, developmental pediatrics, maternal fetal medicine, public health, and then we have a staff that includes a number of folks with quality improvement expertise, some of them with training in Six Sigma and training in the IHI model. We provide training and coaching and facilitation to help the sites themselves use the QI model to implement these best practices. We also we do a lot around data analytics. We collect and share performance measures that the sites can monitor their changes and kind of make decisions based on the data that are objective. We train providers to use the PDSA approach so that they can support their practice improvements. And then finally, many of our leadership staff here previously held positions in state government, and so we have broad knowledge of basically some of the healthcare policy that is relevant to these projects, and we're able to provide policy recommendations to the state to sustain their work. I just want to show you a few examples of the kind of work we do. This here is an example of the data feedback we provide for the Ohio Minds Matter psychotropic medication quality improvement project. This is an example of a monthly report that each participating provider receives from us, and it includes, as you can see, the name of basically each child that they prescribe to, who has a prescribed, where we've identified a prescribing practice that exceeds the target threshold that we're trying to kind of basically control and improve in the project. So it identifies the child's name, their age, how long they've been receiving that prescribing pattern, which physician in the practice is prescribing the medication, and then which of the 3 target measures, if it's 4 or more psychotropics, 2 or more atypical antipsychotics, or receiving an atypical antipsychotic below the age of 6, which of those targets are being tripped, and so that then is used by the medical directors at those practices and by individual physicians to basically look at how they're doing, identify opportunities to improve, and those sorts of things. We also, through this system, have a way of gathering from the providers feedback. We ask them to provide reason codes for the prescribing patterns, and then we use that information in the future to provide kind of targeted learning opportunities. This is another example. This is an example of one of our performance data portals for the MOMS project, where providers on a monthly basis are asked to log in and enter data related to measures of integration of prenatal and behavioral health and social support services for these moms. And then sites are also at the same time able to download individualized reports that compare their performance to the performance of other sites that are participating in the collaborative, and monitor their progress and identify gaps. We also provide monthly performance reports to the state leaders and stakeholders so that they can monitor how the initiative is going and try to address barriers that are coming up, or basically provide leadership. The other key role here is the role of the academic leaders. So we engage academic leaders from the Ohio colleges who are experts in their field. Many of these have national reputations and lots of publications in these areas, and so they really have a lot of credibility. Because of that, they have the unique ability to engage providers and get buy-in, which is often more of a challenge for the state agencies. these academic experts play a variety of different roles. They will conduct research up front and advise the state regarding kind of key leverage points to basically plan the improvement efforts. They will be the face of the improvement effort, the champion in many times. They will develop and disseminate treatment guidelines and provide training to the collaborative, and they'll participate in evaluating the impact and advising the state regarding how to sustain the initiative. They also, because of that unique role, are able to take the learnings from the initiative and these best practices and integrate them into their own training with residents and other types of trainees. So we see that as an added benefit in terms of dissemination. Just want to show you a few examples of some of the work that we've been able to do because of our collaboration with these academic leaders. This is an example of one of the resources we use as part of the Ohio Minds Matter project. We have basically a panel of 25 clinical advisors representing all of the colleges of medicine, departments of psychiatry, and developmental pediatrics. And they've developed a set of medication algorithms that are posted online, and also trainings are recorded and available to practitioners for CME. These are just, to show you at the end some examples of some of the results of our work. So we have commissioned research. This is an example from the Ohio Minds Matter project. The evaluation was conducted by faculty here at the psychiatry department at OSU, and they looked at trends in prescribing over time for participants in the 2 waves of that collaborative project and compared that to the state, to trends in the state as a whole. And what you can see is that for those providers in waves 1 and 2 of the collaborative, they were able to achieve a reduction of about 25% in AAP in antipsychotic medication prescribing, polypharmacy prescribing, and also reduce the exposure to those medications by approximately 6 months among children who were on 2 or more atypical antipsychotic medications. In comparison, you can see the state trend, which is the black line here, was pretty flat. So we felt like we are making progress in some of these initiatives. Another example is from our gestational diabetes project. When we started, we found that only about 26% of women with gestational diabetes in our pilot sites were receiving any type of follow-up postpartum care. And so we've been working with sites on coordination of services, on educating women, and basically tracking on a monthly basis how they're doing and what they can do to improve. After 6 months, we were able to increase that rate to 39%, which is still insufficient. But the collaborative was able to share information with us about their coordination challenges that we're now using basically to form the second wave of the collaborative, and hoping to kind of get that number higher than it is right now. So these are just some examples of the types of work we do and how I think vital the role of the colleges of medicine are to the state for these different types of quality improvement best practice initiatives. I think I want to turn it over now to Heather Reed to describe the Healthcare Access Initiative.
Thanks, Dushka. So I was asked by Nadine to focus on the why, what, how, and results with regards to this effort. And this slide really is reflective of the why. Our MedTap HCA goals include fostering innovative partnerships between academic medical centers and health professions training programs, recognizing the growing need for creating a diverse workforce and enhancing interprofessional education, preparing current and future healthcare professionals to work in underserved communities, and expanding the state's capacity to recruit, train, and retain an enhanced workforce fully skilled to serve the Medicaid population. So this is a list of our MedTap HCA partnerships. As you can see, it includes academic medical centers, health professions training programs, and several state agencies. We're also establishing and exploring some relationships with other potential partners, including the Ohio Association of Community Health Centers, which represents the state's federally qualified health centers. We found that FQHCs often are partners with our schools and universities as community-based placement sites for our HCA learners. Here's a map that shows you all of the various university partners that we're working with through HCA. We currently are working with 10 university partners, including all 7 of the state's academic medical centers. MedTap HCA funds a total of 17 projects statewide. The program has secured more than $57 million in federal funding since its inception in 2012, and the current budget this year is just under $14 million in federal dollars and slightly more than $14 million in university matching funds. So now we're going to get into more of the what and the how of the HCA, as we call it. With a focus on increasing access to care for Medicaid and underserved populations and adequately preparing a healthcare workforce to serve this population, HCA projects generally focus in one of the following 4 areas: behavioral health, training and deploying community health workers, which is a newer thing that we're doing with HCA. It's just started in the last couple of years, interprofessional education, which really crosses through all of the projects, and community-based experiences. So I'm going to kind of quickly run through just a few examples in each of those 4 categories. In the interest of time, I certainly can't talk about all of them, but just to highlight and give you a flavor for what the various schools are doing with regards to these issues. Several of our university partners are engaging in behavioral health initiatives with HCA funds, and this is just one example. Kent State University's program promotes interprofessional communication through course content and clinical experiences with clients across the lifespan. Clinical experiences take place in FQHCs and a variety of other community-based sites, and interprofessional teamwork is stressed throughout the program. Seven of our HCA-funded schools and universities are currently working on CHW initiatives, and as I said, these are newer initiatives and really just getting underway, and we're just beginning to see results from these activities. I've shared on this slide a summary of the work being conducted by Wright State University's CHW program. One of the things they do, in addition to recruiting potential CHWs, is to incentivize those students by offering tuition assistance for up to 20 students. The program places trained CHWs in an interdisciplinary team in primary care ambulatory facilities serving high-volume Medicaid patients. In addition to training CHWs, Wright State is really focused statewide on assistance to community colleges in developing additional certificate programs and on monitoring the numbers of CHWs trained. Interestingly, in Ohio, we do have a certification for community health workers, which is not the case in some other states. Interprofessional education. Most of our 10 university partners are focusing on interprofessional education as part of this initiative. Interprofessional education projects being undertaken vary from school to school, and much of the interprofessional work has both an in-class focus with development of curricula, as well as an opportunity to train interprofessionally in various community-based settings. Cleveland State's MedTap Mentor project is one example of that, and you can see from the slide that their activities include the development of interprofessional and mentor-mentee relationships, monthly meetings, and a culminating group project. And it's kind of interesting that group project carries on and forward to the next group of students that become MedTap scholars through this project. It engages nursing, social work, physical and occupational therapy students, and they also offer an online discussion community, which the students find incredibly valuable. Community-based experiences, and this is the last of the examples I will share, and then I'm going to get into a little bit about some evaluation that we're doing of the project. Community-based experiences really are integral to this initiative as an important learning experience for the health profession students being trained. You know, learning about the social determinants of health in a classroom setting is one thing, but having the opportunity to put that learning into practice in a free clinic, a homeless shelter, or a school-based clinic helps to truly solidify the learning experience. Through its HCA initiative, the University of Toledo has developed several community-based experiences for its health profession students, all of which focus on serving the Medicaid population and are interprofessional in nature. Rocket Pediatrics, a school-based pediatric clinic in Reynolds Elementary, and the Metabolic Health Initiative, a health risk assessment program at the Metabolic Clinic, both foster symbiotic community relationships that provide affordable community care and give HCA students an opportunity to work with lower-income families. Health Grows is a health promotion program that focuses on addressing the social determinants of health with activities such as community gardening and healthy eating demonstrations. So now to the results, and these are preliminary results. We are in the process of completing a comprehensive assessment of the HCA initiative. We are expecting those results by the end of June. And in addition to comprehensively assessing the project, evaluators are also developing a framework to guide sites with future data collection and identifying and characterizing best practices across Ohio and nationally. This is a 3-phase study. We've kind of wrapped up or getting close to wrapping up phase 1 and phase 2, and we're moving into phase 3, really the synthesis of findings. And as I said, we're expecting a final report by June 30th of this year. And so I wanted to just touch a little bit on some of the preliminary results. And I guess I want to start that by saying that it's safe to say that the preliminary evaluation has proven that variation and innovation are common themes. So I characterize that by if you've seen one HCA strategy, you've seen one HCA strategy. From training residents, fellows, med students, and undergrads in social determinants of health to expanding school-based health clinics and working on improving food security, HCA projects have truly been varied in nature and very much community-driven. We found that FQHCs have proven to be effective placement sites for many of our scholars and learners, and virtually all of our schools have relationships in place with FQHCs and are using them as excellent community-based sites for placement of these students. We're also seeing that CHWs are having impacts in their communities, and projects range from a focus on chronic disease management to reducing infant mortality and engaging CHWs in the patient-centered medical home model of care. So the impact of HCA really does seem to extend beyond the numbers. Future opportunities include establishing a collaborative learning environment to allow sites to share their successes. Many of our schools and universities, when they were visited by the evaluators, said that they would really value having that opportunity to hear about what the other schools are doing and to learn from them. And so the HCA team here at the Government Resource Center has begun that process, and we're doing quarterly webinars with all of our schools and universities and offering a learning opportunity for them to hear about what some of the other schools are doing. Also examining the impact of interdisciplinary training in the context of patient-centered medical homes, and looking for ways to share best practices, training models, and curriculum so that this initiative can really be sustainable moving into the future.
Great. Well, thank you very much for those presentations as well. And now we will open up the floor to questions. So please continue to ask questions. We're going to unmute the lines. You can also ask questions in the chat box. So we hope to receive your questions soon. And we actually did get one question that came in during registration. So we will answer that now. And the question is, are there examples of state-university partnerships which use Medicaid population data to inform and drive local collective impact initiatives to support outcomes for defined populations? So Dishka will answer the question first, and then we will turn it over to Dr. Polikoff to answer from the UMass perspective.
I think we have probably a couple different examples at the Government Resource Center. One just from the the Ohio Minds Matter project that we were describing. We actually that project initially set out to focus our pilot efforts on 3 communities in the state where there were already local partnerships and a lot of work being done. And so we, in each of those areas, would provide performance reports to those regions on a quarterly basis, which they could then use to enhance their partnerships as well. And we saw that as kind of the best way to make sure that our project succeeded, because at the local level we wanted to make sure those partnerships were taking place and children had access to a wider range of resources other than medication. I think there are other examples from some of our survey work, the UMass project, where local systems have done things. I don't know.
This is Jerry Friedman at the Ohio Colleges of Medicine Government Resource Center. One of the first initiatives that the Government Resource Center took on was initially called the Ohio Family Health Survey, and it was an effort by the state to understand access and coverage. That became an important consideration in terms of looking both at Medicaid expansion and the availability of sufficient network of providers to address the needs of the nearly 600,000 people who were covered in the various aspects of that expansion.
This is David Polikoff again. I guess I would add to that in Massachusetts, our expertise in analyzing Medicaid claims data has allowed us to participate in and have an impact on a pretty wide range of collective impact initiatives or community initiatives. A couple of examples would include some benefit expansions. For instance, when dental health benefits were cut during a tough budget season and reinstituted, we did a lot of claims analysis around where the gaps in coverage were that supported a stepwise reimplementation of the Medicaid dental benefit. The last statewide health care reform bill in Massachusetts, Chapter 224, provided a grant program that the Department of Public Health uses to support communities in becoming healthier communities. And they made grants to 9 communities around the state, and we have done some claims data analysis and other analysis to support the implementation of initiatives in some of those communities. Those are just a couple of examples. We have such deep expertise in the analysis of Medicaid claims data